Pericarditis is a common condition with diverse etiologies. In Western countries, the majority of cases are idiopathic, whereas tuberculosis remains the predominant cause of pericarditis in endemic countries, mainly in Africa. Hello, my name is Awais Malik. I'm an assistant professor of medicine in Department of Cardiology at Mayo Clinic in Jacksonville, Florida. In this video, I'll be summarizing a review article titled Acute and Complicated Inflammatory Pericarditis, A Guide to Contemporary Practice. The most common features of pericarditis include pericardial chest pain, friction rub, EKG changes, and findings of pericardial effusion on echocardiogram. Chest pain is often described as constant, sharp, and pleuritic. It is often positional as it improves in upright posture and worsens in supine position. It is present in up to 90% of patients. Friction rub is often present in about 1/3 of patients, and it is pathognomonic for diagnosis of acute pericarditis. Classic EKG findings associated with pericarditis may include diffuse ST elevations and PR depressions and may be present in up to 60% of patients. An echocardiogram may show an effusion in about 2/3 of patients. If a patient has 2 out of these 4 features, then they are diagnosed with acute pericarditis. Other supportive findings may include an elevated CRP level, more than 3 mg per liter, or the presence of pericardial inflammation on cardiac MRI. Now, the treatment of pericarditis is guided by staging, and there are 2 main categories here. If a patient has a first episode of pericarditis and the symptom duration is less than 4 to 6 weeks, then they are categorized as acute pericarditis. The remainder of patients with incessant pericarditis that lasts for more than 4 to 6 weeks, chronic pericarditis that lasts more than 3 months, recurrent pericarditis where they have a relapse of symptoms after a symptom-free period of 4 to 6 weeks, or constrictive pericarditis, which can be chronic or can be part of an acute episode. All these stages are grouped into complicated pericarditis. For both acute and complicated pericarditis, high-dose NSAIDs are the first-line therapy. The most commonly used agents here are high-dose ibuprofen or indomethacin. In post-MI setting or in patients with coronary artery disease, high-dose aspirin is preferred. NSAIDs are typically tapered over a 1 to 2 week period after resolution of symptoms and normalization of CRP levels. As far as colchicine is concerned, it is also considered a first-line therapy along with NSAIDs. It has been shown not only to reduce the burden of symptoms, but it also decreases the risk of recurrence in both acute and recurrent cases. In cases of acute pericarditis, we recommend 3-month duration of colchicine therapy. In complicated pericarditis, the duration of colchicine is extended to 6 months. And then glucocorticoids are used as a second-line therapy due to high risk of recurrence associated with them. They're mainly used in patients who have contraindication to NSAID therapy, or the patients have a systemic inflammatory process requiring steroids for other reasons, if they are pregnant, especially in the 3rd trimester, or have an acute kidney injury or advanced chronic kidney disease. Typically, we use low-dose prednisone at 0.2 to 0.5 mg per kilogram per day, and steroids are tapered slowly over 2 to 3 month period. Typically, when we use steroids, we use colchicine for 4 weeks after discontinuation of steroid therapy. The newer agents are the IL-1 receptor antagonists, and advances in IL-1 receptor antagonist therapy has revolutionized the medical management of recurrent pericarditis. They offer a safe and highly effective option for patients who were previously categorized as refractory to medical therapy. The 2 most extensively studied agents are anakinra and rilonacept, and they have shown excellent treatment responses in patients who are otherwise dependent on steroids. Newer agents such as goflicicep have also shown promising results in clinical trials. Unfortunately, withdrawal of IL-1 receptor antagonist therapy is associated with a high risk of relapse. But recurrence rates have been shown to be lower when opting for longer duration and slow tapering of these agents. Lastly, among patients in whom medical therapy cannot be withdrawn, or those who do not desire to continue medical therapy indefinitely, radical surgical pericardiectomy can be performed at an expert pericardial center to provide durable results. Thank you so much for your time. I really appreciate it.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research. All rights are reserved, including those for text and data mining, AI training, and similar technologies.